com, and the pin is 14825. So this was intended for a live broadcast for a conference for the Student National Medical Association, and it was defeated by one single headphone jack. They were unable to connect to the main speakers, but they've asked me to record and to send it along to them. So we're going to do that. Basically, this is a lecture that was called Leadership Begins Where We Live, Learn, Work, and Play. And the idea behind this is a leadership conference that medical students and residents are attending. And Student National Medical Association is the largest minority medical association in the country, and they have their yearly leadership summit. So today we're going to talk about how leadership begins where you live, learn, work, and play. I'm glad we tried this with millennials because they're more flexible with technologies. I think boomers would have given up sooner, but we're going to keep trying. So first, we're going to have our first phone-in request, our phone-in poll. So at the live.votebox.com with the pin 14825, if you can just put in where did you go to high school, what state or what country, and you have to use your cell phone, live.boxvote.com with the pin 14285, and we'll give you just a little bit of time. It's in the comments, and you can see live.boxvote.com 14285. Oh, 14825. Okay, so we're going to get that going. And we're going to start now and see if we can get any things on that. Of course. Oh, okay. Refreshing. Okay, anyway, so thank you. We're going to proceed. So, I was asked to do a lecture on health disparities, and I think words are very important. So whenever I'm asked to do a lecture on health disparities, I never do the lecture on health disparities. I do it on health equity, and I think that the reasoning behind this is very sound. The idea is when you're in a situation, I believe that moving positive and forward is the best way to go. When you look at the roots for health disparities, dis from the Latin not, and par from the Latin meaning equal. So the word itself means not equal. But I think it's better for us to pursue health equity, and I really love the root of equity. It's from the Latin equitas, and equitas actually means fairness or justice. And so what we're looking for with health equity is not the absence of illness, it's the presence of justice. And I think that that's a critical point. So, when we're looking at what this health disparities calls, when they say disparities, they say a particular kind of health difference that is closely linked with economic, social, or environmental disadvantage. Health disparities adversely affect groups of people who have been systematically and historically linked to discrimination or exclusion. When you think about health equity, they look at the definition, it's a principle underlying a commitment to reduce and eliminate disparities. I like it because it's the commitment to reduce or eliminate. I know there's a lot of people that do a lot of really good research on health disparities. I don't want to be a health disparity researcher. I want to get rid of health disparities. And I think reframing it as pursuing health equity is striving for the highest possible standards of health for all people. And the neatest thing is that you actually, to do equity, you have to put extra effort on the people that need more. I think one of the things that's really interesting about medicine nowadays, I'm a family physician, I'm a full spectrum family physician. I do everything from prenatal care to hospice and everything in between. Delivering babies, taking care of kids, women, men, elderly, the whole gamut. And you don't even have to be sick to come to us. We'll take care of you and help you stay well. But the thing is, one of the things that you come to realize is that as a physician, we don't actually have that great an impact on healthcare outcomes. The data show that if 100% of the outcomes come from the addition of our impact in healthcare, like what we do in the exam room, what we do in the clinic, is 20% at the most. Some studies actually have us at about 10%. So the overall outcomes for our patient, we have about 20% impact. The rest of it, the vast majority, these are, is 80%. 80% of the healthcare outcomes are due to the social determinants of health, or social determinants of health. So things like socioeconomic factors, education level, employment opportunities, the physical environment, health behaviors. Even genetics has a very limited impact. So if we're in this situation where we're looking at, this is our clinical impact, only being 20%. If we're going to be leaders, and that's what this conference is about, if we're going to be leaders addressing health inequities, we have to get into that 80%. That's the money. And leadership is a critical part of this. And especially the next generation. You guys are the future. And it's lead, follow, or get out of the way. And you've chosen to lead. And I think that's critically important. So, one of the things you have to remember, in addressing this 80%, we need leadership. And just to say to yourself, what is leadership? And as a leader, I think it's critically important that you find your own definition of what that is. Warren Bennis says, leadership is the capacity to translate vision into reality. Bill Gates says, as we look ahead into the next century, leaders will be those who empower others. My personal definition of leadership, what I've led my life by, is leadership is having the vision and the skills to guide change. When you look at the skills that we have to build things like inspire and motivate others, display high integrity and honesty, solve and analyze problems, drive for results, communicate powerfully and prolifically, build on relationships. That is key, building relationships. Display subject expertise. You don't have to be the world's finest person or the leading expert, but you need to know the subject that you're talking about. And since we deal with medicine, it's critically important that when we engage, we come from that direction. And you have to display a strategic perspective. You have to be able to see the 30,000-foot view. And I think it's also important as physicians that we also see the one individual. I like to see the whole forest, but I think seeing that one tree is critically important too. One of my favorite stories, one of my residents told me, and I think that this works with the whole idea of, should we work only at the highest level or work with the individual patient? In order to do this, we actually have to do both. It's both and. There's a great story about a guy, he's on the beach, and he sees thousands and thousands of starfish. And they're all just laying out in the sun. And there's this one guy, he's going down, he's bending down, picking up one starfish at a time and tossing it back into the ocean. Just picking up one, tossing it back. Picks up one, tosses it back. This guy runs up to him and is like, "What are you, an idiot? There's thousands of starfish on this beach. Do you think it really matters that you're doing that?" The guy looks at him, he bends down, picks up the starfish, tosses it in the ocean, he says, "It mattered to that one." So that's the thing. We have to do both and. We have to be able to work at the policy level and lead, and we have to be able to go into each individual patient room and give them 100% of us. So, the other critical part of leadership is developing others. I think it's... Huh?
I think it disconnected. I'm okay.
I'm in? Okay, good. So, I think that as I was saying, one of the most critical parts of leadership is helping others lead. Leaders build leaders. So, when we're thinking about addressing...
I think so, yeah.
Okay, good. So when we're thinking about addressing the social determinants of health, one of the things that we have to understand is when you say social determinants of health to policymakers, they just shut down. That's some big fancy academic language. They don't want to hear about it. So it was really great. Robert Wood Johnson Foundation did an extensive study on how to communicate regarding the social determinants of health to policymakers. They did a bunch of focus groups. They said, what would be a way that you could hear this? And they came up with probably about 6 phrases, but my favorite one that really, I believe, works very well is health begins where we live, learn, work, and play. So, and again, health begins where we live, learn, work, and play. So, the idea that this 80% impact on our healthcare outcomes is strictly evaluated by where we live, learn, work, and play. So, when we think about policies, all of those areas are impacted by political choices and policy choices. And choices that have been made decades ago. So, we just break it down into smaller pieces. If we think about the idea that this 80% is made of live, learn, work, and play, we have to address it in a systematic manner. These are structural policies that have been in place. When we're talking about living, has anyone heard of redlining? If you've heard of redlining, you can nod your head and feel superior. If you haven't heard of redlining, basically, in the 40s and 50s, there was a systematic policy of not giving mortgages in neighborhoods that had a high minority population. They were considered places that were at risk, and so even folks who had similar economic ability were not able to get mortgages in places like that. A lot of these places, most of them were minority dominant areas, and as they became, some of them were white areas that minorities would move in, and through things like what's called blockbusting, realtors would come in, tell the white homeowners that there's black people moving in, the neighborhood's going to go down, you need to sell your house, and they would buy the houses very cheaply, and we had white flight to the suburbs. The thing is, when those neighborhoods became predominantly minority, if you look at the idea that if you want to sell your house, you want to sell it in a market that has 100% of the possible buyers. But if you're selling it in a market that only has 12 to 20% of the possible buyers, what's the chances that your house is going to appreciate? So even people who bought houses at the same time, if they could, who had the same income, if one was in a black neighborhood and one was in a white neighborhood, the white person in the White House, that's sort of an unwanted pun. The folks that were white, their house would appreciate. The folks who were black, their house would not appreciate. And it wasn't necessarily because the black people had less money or less input. You're in a decreased competitive environment where fewer people can actually get mortgages. And so those neighborhoods spiraled into places that had limited political power and limited economic power and limited educational ability. And if you look on, there's a great website on Redlining, and if you look on those websites, you can find out what your city looks like, and you'll note that the areas that were redlined in the 30s and 40s are also the areas that were cut apart and isolated by the interstate highway systems. So you have a neighborhood that's continually incurring more and more risk, has less and less power, has less and less economic power, and is physically isolated. So, policies that were in place 50, 60 years ago have impacted the wealth of minority communities today. So, where we learn, what kind of policies affect our health in regard to learning? If you look at the zero tolerance policies that were initiated in the late 80s, early 90s, the first thing you note is an increase in school suspensions for minority children. One of the leading indicators of entering the school-to-prison pipeline is recurrent suspensions in middle school. And you might say, oh, well, if you misbehave, this is what's going to happen to you. But the fact is, the data show that black and brown kids are perceived as more violent and more disruptive and are punished more for the exact same behaviors that white kids do. One of the latest studies was out last year from Stanford, and it evaluated preschool teachers looking at toddlers' behavior. For the same behaviors, black and brown kids were considered more unruly and requiring more discipline. And as I said, more likely to be suspended and have harsher punishment for the same exact behavior. So, live, learn, work. When we think about where we work, significant amount of historical consequences as a result of employment access. Since the end of slavery times, I hate to bring up slavery, but it's a thing. In a situation where even in the mid-20th century, when we initiated Social Security, domestic workers were excluded from Social Security. The majority of domestic workers at that time were black or brown. Access to trained professions, access to higher education, access to union training, all very segregated and limited. So, the lucrative work is segregated, and retirement benefits, healthcare benefits, all of the government subsidized things that we do for employed people, you don't have access to. So in your situation, 40 years later, that family's not accumulating wealth. You're not able to accumulate multi-generational wealth, but what's clearly set up is an opportunity to reinforce intergenerational poverty. Because as one generation grows, they still have to take care of both the older generation and the younger generation. Does not give them a chance to accumulate wealth. So, live, learn, work, play. Neighborhoods that are under-resourced and low wealth and more likely black or brown are also more likely to have toxic industry and have the sequela and dangers of toxic industry. Where I live and work is near North Minneapolis. There is an extensive amount of industry on the Mississippi. And the only place that it's there is next to North Minneapolis, the poorest urban neighborhood in the state. There's a shingle burning factory. Not 100% sure why that happens. But I do know that we have the highest rate of asthma exacerbation and hospitalizations for asthma for children in the city. And it peaks in the times when there's higher particulate matter. It's also very interesting that the company is told whenever there's going to be an evaluation of their air quality. They're warned in advance when they're going to be evaluating the air quality. And guess what? They seem to be passing. Also, the idea of green space, definite policy choices. And one of the things that we know as physicians is that green space increases and encourages activity and is both mentally helpful and physically helpful. Neighborhoods, black and brown neighborhoods that have been in these situations, low wealth, decreased likelihood of having as many parks, increased likelihood of concern regarding safety in those parks. And you're in that situation where you may have a park, but you're concerned that you can't let your child go there. All of these things are structurally in place and impact the health of our patients. When we look at it, the health quality of our patients directly influenced by where we live, learn, work, and play, and how their life events go. I don't know if a lot of you know about what's called the ACEs score, but it's Adverse Childhood Events score. And it's very simple. You can Google it, and you should probably get your own score. It talks about if you were exposed to physical abuse before 18 years old, sexual abuse, emotional abuse, physical or emotional neglect, exposure to domestic violence, household mental illness or substance abuse, and parental separation or divorce, and incarceration of a family member. Now, each of those will give you a point. And the thing is, if you are in a situation where you have at least 4 adverse childhood events, you have a 700% more likelihood for alcoholism. You have a 300% more likely cancer, cardiovascular disease, COPD, emphysema. Not saying that the events cause directly, but what we understand is in these situations, kids that grow up in these situations, no matter what color they are, if your scores are over 4 or more, you're definitely at risk for significant chronic illness and earlier death. So, these are the kinds of things these are the structural, systematic things that are in place that need to be addressed. What we need to do is we need to talk about policies that influence where we live, learn, work, and play, since it's driving 80% of healthcare outcomes. Structural inequality leads to health inequalities. And that's something we have to really drive home. Systematically addressing structural inequity is the only way that we can get rid of health disparities. And one of the things that I would say is our best option is to stop thinking in silos. We have to understand that it's about health in all policies. Every single policy proposal needs to be examined for its healthcare impact. Things like addressing health behaviors at a community level. Tobacco 21, raising the age of tobacco consumption access to 21 years old. Why would we do that? One of the biggest reasons is because we know that the earlier a child starts smoking, the more likely they will continue to smoke and the more likely they would be at risk for chronic illness. This is one of the areas where we have both our medical students and our family medicine residents participating. Minnesota did not do a statewide Tobacco 21, but what's been happening is independent communities have had votes. And I think there's like 6 places that have done it in the last 2 years where they've raised the smoking age to 21 in efforts to curb youth smoking. And that's a community-level response to health behaviors. We depend very much, we're America, and we really like to have people independently choose to do things. But it's actually quite a good idea to do some of these things at a policy level, because that makes independent choice a lot easier. So providing an environment where it's easier to make the good health choice is what we're looking for when we're addressing policy at a community level. So here's the thing. When people are talking about policy, a lot of times people don't completely understand what it's about. So, I was very fortunate. I got to do a health policy fellowship with the Department of Health and Human Services, and I had a lot of really good teachers. And one of the folks, he would give us this sort of way of structuring things in our mind. He'd say, data. And we were all physicians. So he was like, data. He's like, you physicians really love data. Actually, there were some dentists too. It's like, you guys love data. You like your numbers. It's not helpful. He's like, but data in context. So data in context is information. So data in context is information. And the thing about information is, well, a perfect example. When I'm teaching in the hospital, if I have a third-year medical student and they tell me the blood pressure is 120/80, I just sort of look at them and I wait, and then they're like, oh, that's normal. So the number didn't mean anything until I knew that they understood that was normal limits. So data in context is important. But when you look at policy, policy is information in action. It's our collective response to a challenge. And data often drives information, and we hope it drives policy. But more often than not, it's stories that drive policy. I'll give you an example. I believe it was back in the early 2000s, a Montana city, for about 6 months, they had a smoking ban in all restaurants and bars. 6 months. And then the smoking ban got lifted. People were able to smoke in the restaurants and bars again. During the 6 months that no one was smoking in restaurants and bars, a couple of the local doctors noted there was a significant decrease in all cardiovascular and chest pain admissions at their hospital. A significant decrease. And they took this information. It was amazing. A couple of Montana docs, they took it, they got published. I think it was in the New England Journal. It may have been New England Journal or JAMA. But really good information about the impact on their community of smoking. Smoking ban was not in place, high level of chest pain and cardiovascular things. Smoking ban comes in place, lowers the level, smoking ban lifted, and it returns up to the level it was. So the data and the information look great. So you'd think that that would have influenced their choice to reinstitute the smoking ban. It didn't, because the policy that was put in place by people who found that the other stakeholders had more compelling stories. The other stakeholders, like the bar owners and restaurant owners, who are like, I got to keep the lights on, I got to pay my mortgage, people won't come if they're not able to smoke inside. So it wasn't until 6 years later that a statewide smoking ban was instituted. And that's when that town actually went back to the smoking ban. So, stories. Stakeholder stories will eat data and information for lunch. So one of the things we have to do as leaders is learn how to tell stories to address these kinds of issues, because the policymakers, they need to hear from us, but they have to hear it in a way that they can understand and drives things forward. So Tobacco 21 is an excellent way of doing a community level response to poor health behaviors. Healthy breakfast, healthy school breakfast, healthy school lunch. Providing non-suspension policies in school systems. When you want to replace the very unhelpful and punitive approaches with programs like restorative justice, those programs aim to address the challenge of discipline in a manner that promotes growth of all the involved parties, as opposed to excluding one and sending them into the school-to-prison pipeline. Other ways to address things at health at a community level. Transportation policies that provide poor neighborhoods access to work environments. I work in North Minneapolis. A few years back, one of the things that was going on is they were deciding which way to bring the light rail from the suburbs to downtown Minneapolis, and also down as far as to the Mall of America. So downtown, Mall of America, all these places, a significant amount of job and employment possibilities. The neighborhood I serve, North Minneapolis, only 50% of the households have cars. So you're in a neighborhood where only 50% of the people have cars. It's a limited transportation response to trying to get employment. If you put a train system in that area that allow them to get to downtown and the Mall of America in a expedited fashion, increase the likelihood that they can maintain employment. So the docs in our neighborhood, we all wrote in, we all did some stuff. And other people wrote in who said things like, well, if you go through North Minneapolis, it's just going to take a bunch of thugs to the Mall of America. That is a direct quote from one of the reports. And then I wrote back to them and said, you know what you call a thug at the Mall of America? An employee. But they didn't hear us. They decided to actually go completely around North Minneapolis. So the suburbs are very pleasantly attached to downtown. But for north, you still have to take 2 buses. That is not considering things like the fact that employment improves the health of not only that person, but their entire family. So, another area that is, I think, significantly necessary in policy, and we're having a lot of challenges with it nowadays, is access to safe and effective reproductive information. And I want to just hit both of that, safe and effective. We have the opportunity right now where we've had a significant decrease in teenage pregnancies. The leading reason we have a significant decrease in teenage pregnancies is low-cost, long-acting birth control. And it's critical that we maintain access to effective and safe reproductive options. All of these things and more are different ways that we can engage in health in all policies. And as physicians and medical students, it's our responsibility to take this as a very important way to address our patients' health concerns. You can't fix it in the exam room. You think you can, but you can't. If you're looking at it, and you can't beat the 80% with the 20. When we have health in all policies, when we have that, we will have justice. We will have the equitas. We have the health equity that we're looking for. When we're looking, so one of my favorite quotes, and this may seem like it's an outlandish thought that we can impact the 80% by our participation in policy. But it's critical that we think about these things. One of my favorite quotes is from Ellen Johnson Sirleaf, first woman prime minister, I believe, or president in Africa. And her quote that has always touched me is, she said, "The size of your dreams must always exceed your capacity to achieve them. If your dreams don't scare you, they're not big enough." And I think that that's critically important that we think about. If we're dreaming about bringing equity and fairness into health policy decisions, we have to participate in that. It's like physicians must be engaged in that. We have to lead. And, you know, I'm always a big fan of the lead follower, get out of the way. But there's nicer ways to say it. So, how do we do it? We're living in some of the most interesting times. And that used to be a curse, apparently. We have a polarized populace, often very antagonistic and violent. But it's not going to get better unless we're the ones that work on it. It's like, we can do it, but we can't do it alone. The whole idea about leaders building leaders is real. My big motto is lift as you climb, build as you grow. The only way out is through. It's through personal growth. It's through engagement in our communities. It's through engagement with our elected officials. It's through willingness to stand for a purpose and to teach others to do the same. It's not easy, but it must be done. Thomas Paine, one of our few founding fathers that didn't own slaves and actually actively spoke out against slavery, when told about the interesting times he was living in, what he said actually resonates with me now a great deal. If there must be trouble, let it be in my day, that my child may have peace. It's time for us to stand for a purpose. As physician leaders, addressing health in all policies is one of our biggest ways that we can impact the care of our patients, the care of our communities. I always like to end with one of my favorite poems. It's about purpose, because I think standing for a purpose is the most critical things we can do now. So, it's called The Way It Is. There is a thread you will follow. It goes among the things that change, but it doesn't change. People wonder about what you're pursuing. You have to explain about the thread. But it's hard for others to see. While you hold it, you can't get lost. Tragedies happen. People get hurt or die. You suffer and get old. Nothing you do stops time unfolding. You don't ever let go of the thread. Thank you. Feel free to leave me questions in the comments, and appreciate your patience with our technological difficulties. And thank you for the SMA folks for inviting me, and I hope the rest of your conference goes well. Take care.